Hello, everybody. Okay, so this lesson is going to be on somatic symptom and dissociative disorders. Your ATI does test you on this a little bit. So obviously we need to talk about it, and I also will test you on it as well. Somatic symptom and dissociative disorders are not the most common, but people do deal with them, especially after trauma or in response to a trauma, especially some dissociative disorders like depersonalization and derealization. Okay, so some learning objectives. We're describing the impact of somatic symptom and dissociative disorders on the client's overall health. Explore epidemiological, that was tough, and etiological risk factors that contribute to client experiencing somatic symptom and dissociative disorders. Differentiate the clinical presentation of clients experiencing somatic symptom and dissociative disorders. Explore the role of caring for explore the role of the nurse caring for the client experiencing somatic symptom and dissociative disorders, and applying the nursing process through the use of clinical judgment functions while providing care for clients experiencing somatic symptom and dissociative disorders. We're going to go ahead and do this case study as I do these lectures. So if you are listening to it in your car, I'm going to read like everything and we'll work through the process and all that stuff. All right, Jennings is a 45-year-old client who reports of chronic pain. They take multiple over-the-counter supplements and medications. They're checking into the clinic to be seen by a psychiatrist because their primary healthcare provider is requesting a mental health evaluation. Jennings is angry about having to be evaluated for mental health concerns. Okay. So when we talk about somatic symptom and related disorders, somatic symptom disorder, abbreviated SSD, and related disorders involve a person having a significant focus on a physical concern or complaint that is a result of disruption in daily life. So just as a reminder, this is still the same as we've always talked about, right? When we talk about mental health disorder, this is a disruption in functionality, okay? Stigmatization is when emotional distress and psychological issues are exhibited by physical manifestations cannot be explained medically. So, just because I have children, I have obviously a lot of children examples. But if anybody has children, what do many kindergartners, first and second graders complain of? A stomach ache, right? In the morning, Mom, I have a stomach ache. I can't go to school. If anybody in here is a school nurse, oh, I have a stomach ache. The stomach ache is there's no cause of the stomach ache, right? They probably have some anxiety, some separation anxiety, some emotional distress, which is causing a physical issue like a stomach ache, okay? It's not due to a gastric issue. It's not due to constipation. It's not due to anything else but the emotional distress of having to go to school as it pertains to a child, okay? An individual is not diagnosed with somatic symptom disorder simply because they have medical causes for a symptom that can't be defined, but rather due to the feelings, thoughts, and behaviors being out of proportion to an illness, okay? And so this is really important. So if the patient is dealing with lots and lots of stomach aches due to anxiety, but they are taking it a step further and constantly researching abdominal pain and constantly feeling like, they've got a ruptured aorta, or they have an aneurysm, or they have a peptic ulcer disease. And then now they're going to the emergency room often and they're seeing different types of doctors. This is becoming debilitating, okay? Their behaviors, thoughts, and feelings are directly related to the stomach ache, which it's not really a stomach ache, it's just anxiety, okay? So clients who are diagnosed with these are with somatic symptom disorder, they're not faking their manifestations, okay? So their manifestations often include pain, gastrointestinal issues, and sexual difficulties. To them, this is real, okay? Just like you have your 5-year-old complaining of stomach pain before they go to school, they're not making it up. They really have the stomach pain, okay? But it is not based in anything, but based in, there's another emotional component. Persistent symptoms like pain can cause disruptions in daily life. We do need to always make sure that we're working with the treatment team to rule out any possibility of a psychological understanding cause for the symptom before considering somatic symptom disorders. So let's figure out, is there an anxiety issue? Is there depression issue? Is there something else going on? I mean, there's numerous of things that could be going on. Okay. A couple of others that ATI talks about is illness, anxiety disorder. This used to be the hypochondriac, okay? So everything is wrong with them, right? Often misinterpreting symptoms that may seek extensive treatment as a form of relieving their anxiety, okay? So I don't know if any of you in nursing school, when you took med surge, you have a headache, you have a brain cancer, you have a cough, now you have lung cancer, you have heartburn, now you have a peptide. I mean, everything, right? And so that would be in the net, but it's not even just stops at that. It's now I have to go seek treatment. Okay. And so it's just, it's another just based in anxiety. And then we have functional neurological symptom disorder. I'm not going to test you on this, but it is also known as conversion disorder. And this is where the client may experience motor weakness, paralysis, tremors, reduced tactile, visual, and auditory senses, in some cases syncope. And this is testing for ontological biological concerns of these symptoms that would result in a negative finding. And so this is interesting. A client may appear to have an epileptic seizure, but if the client was connected to an EEG, the test would show no indications of a seizure. I literally have had a patient. She had, at the time it was called conversion disorder. Now it is called functional neurological symptom disorder. She was having quote unquote seizures, and she was having like 6 a day. And she was on our unit, but she wasn't having a seizure. During her seizures, she would legitimately like turn purple, but then like give a thumbs up that she was okay. Okay. She was not having a seizure. This was all based in other things, okay? I had another patient who got hit by a car, and now granted, I don't know if this would have been conversion disorder. I'd have to look at the DSM, but he got hit by a car. He was homeless. Nothing was wrong with him. They did all these tests, but he couldn't go to the bathroom. Like, he couldn't get up and walk. But if he had to go to the bathroom, he would get up and walk to the bathroom when no one was looking. And so it's kind of like, okay, bro. I wasn't his nurse. I just heard about him and around. So, all right. And then we have fictitious disorder. So this is when the client falsifies their symptoms to themselves or others, even when there is no external reward in doing so. Okay. So fictitious disorder, I'm trying to think. I haven't seen the documentary, but I don't think Scamantha would be fictitious disorder because she was getting money. But I can't think of an example of fictitious disorder. I'll try to think of one and present it in class. But in some cases, the client may falsify symptoms for personal gain, such as getting time off of work, and this would be malingering, okay? So Scamantha, she would be malingering, okay? So she was falsifying that she was super duper sick, had cancer, and all these people were raising money, and I think she was raising you may correct me, but I think she got like $1 million based on all these fundraisers that she did to like help her with medical bills and blah blah blah. Okay. This is not fictitious disorder. People with fictitious disorder, they don't want anything. They're just doing things, okay? Patients that are malingering, they're doing things for personal gain. When we talk about dissociative disorder is characterized by disruption in the way that the memory, conscious, identity, emotion, motor control, and behavior interact with each other. Okay? And so dissociations can be present in a person who has experienced a history of trauma. When a client experiences dissociation, they may re-experience previous trauma, which switch to an altered personality, have flashbacks or nightmares. All right. And so this is kind of looking some people. So you have depersonalization. Well, we'll go through it. It's down here. Symptoms of dissociation are classified into positive and negative presentations. Positive is described as depersonalization, division of anxiety or derealization. And then when we talk about negative dissociative symptoms, these are classified by lack of control or access to mental functions that were previously controlled or accessible, like lack of memory, also known as amnesia. Okay. And so when we talk about depersonalization, derealization, this is a detachment from the patient's surrounding. They may say that they're in a dreamlike state floating outside of their bodies. Okay. So I had a patient over the past summer. She was 15 years old and she had a pretty decent history of emotional, sexual, physical trauma. And she experienced a lot of derealization based on just situations where she felt like she was back in a setting where her trauma occurred. Okay. When we have dissociative amnesia, this is described as being unable to recall events related to your history and is not consistent with normal forgetting. So, for an example, a client may be unable to recall specific events, recall specifics about an event or an event in their own personal history. And so so for me, I have dissociative amnesia related to traumatic events that I dealt with as a child. Okay. And so there's some things that I just cannot remember. I cannot recall. I know some things just based on, somebody saying, yes, I witnessed this thing happen. But I have literally no recollection in my brain. Okay. When we talk about dissociative identity disorder, also known as DID, this is that whole multiple personality, Sybil kind of thing. Somebody has like 17 different personalities in their brain. This is extremely rare. I think some psychologists, psychiatrists, nurse practitioners, physician's assistants don't agree that this is like a real thing, but it's here. If anybody ever watched One Life to Live way a long time ago, Jessica had a DID or multiple personality or split personality disorder. And this becomes a diagnosis when the client experiences a disruption of identity characterized by two or more distinct states. Okay. And if they're in one state, they may have gaps of memory. Okay. And this is, like I said, two different identities, also known as alters, and they function independently of one another. They may have their same memories and behaviors, but they also may remember things of like the other person, the other alter, whatever. Okay. So when we're talking about functional neurological symptom disorder, this is what we used to call conversion disorder. It's seen across the lifespan, has a better prognosis in younger children versus adults. Okay. In this little section right here, somatic symptom disorder, you can go ahead and read this on your own. It's essentially just the exact same thing that we talked about. All right, let's continue the case study. So Jennings has chronic headaches, shoulder pain, and neck pain. They have a medical history of multiple surgeries, including gastric bypass, carpal tunnel release, septoplasty, and knee surgery. Jennings spends their time going from provider to provider in an attempt to have their medical concerns addressed, find relief from their manifestations, and identify the medical cause for their manifestations. They have been able to work to their medical concerns due to their medical concerns and are frustrated that there has not been a definitive medical diagnosis. Jennings believes there is something seriously wrong with them and has very high anxiety related to their health. A nurse has the history and physical assessment data from Jennings' admission record. Which of the following disorders would Jennings most likely be diagnosed with? So Jennings has this chronic headache, shoulder, neck, and back pain, or headache, shoulder pain, and neck pain. They have a history of multiple surgeries, and they go from provider to provider trying to address their concerns, which is these headaches, which is just pain. They're in a lot of pain. They've been unable to work due to their medical concerns and frustrated that there is no definitive diagnosis, okay? They think that there is something wrong with them and have a lot of anxiety related to their health, okay? So when we talk about fictitious disorder is essentially saying that what? What do we talk about fictitious disorder? This is when they are dealing with a diagnosis, and they not dealing with a diagnosis, I'm sorry. Fictitious disorder is when they are falsifying their symptoms to themselves or others when there is no external reward for doing so. He doesn't see, or they do not seem like they're falsifying their pain. Okay, they're frustrated, they have high anxiety. So I would kick that out. Illness, anxiety disorder. So we talk about illness anxiety disorder. This is when somebody this is that hypochondriac, right? So they have they may be misinterpreting their symptoms and may be seeking treatment as a form of relieving their anxiety. In some cases, clients may need to seek treatment and receive medical diagnosis, leading to a paradoxical reaction, causing more severe anxiety. Okay, so this kind of sounds like what Jennings is dealing with, so we'll keep that to the side. Functional neurological symptom disorder. This is like our conversion disorder. So this is where there's like a lack of something, or like I don't want to say faking. Let me get the more appropriate word. So when we're talking about the functional neurological symptoms, this is this motor weakness, some sort of like decline or some sort of issue like epileptic seizure, maybe passing out or whatever, that would be an indication for their problems. And it doesn't appear as though, I mean, he had surgery, so some things were wrong with them. So I don't think that's it. And then dissociative disorder, this is that out-of-body experience, okay? So we kind of went through all of these, and I think it's illness anxiety disorder. Let us see. Yay! And you can go ahead and read this part on your own. So just as a quick FYI, dissociative disorders may develop from any point in early childhood through older adulthood. Events experienced across the lifespan can cause for symptoms of dissociative disorder. Nurses should investigate the client attempted or plans to resolve their feelings related to a stressor rather than the stressor itself. Dissociative disorder can develop from actual trauma, loss, or physical stress like a motor vehicle accident, as well as a perceived loss, physiological stress like failing an exam or interview. Okay, and so this is just very important that you're understanding that this can happen at any time, essentially based in anxiety or stress. So when we're talking about like the prevalence of somatic symptom disorder, the prevalence is not really high. It's a 4 to 6% in the general adult population. Female tend females tend to report more somatic symptoms than males. Thus, the prevalence of somatic symptom disorder is likely to be higher in females than males, okay? When we're talking about dissociative disorders, like we had already talked about, this is a lot of times due to some sort of like trauma. And this is interesting. I love me some research. When looking at families of clients with dissociative disorders, they were often explained entirely on the basis of exposure to trauma or learned behavior. All right, so that's pretty interesting, right? Comorbidities for somatic symptom or disorder or somatic symptom and related disorders. Essentially, these people are going to have, comorbidities of major depression, generalized anxiety disorder, and substance use disorder. Okay. And a lot of these clients may be on an antidepressant medication to help with their anxiety or their depression. When we talk about dissociative disorder, dissociative disorders have comorbidities of post-traumatic stress disorder, substance use disorders, antisocial personality, or depressive disorders. And after experiencing the episode of dissociative amnesia, patients can also experience guilt, rage, dysphoria, shame, and psychological conflict. Okay. All right, let's get back to Jennings. So Jennings has been taking hydrocodone for a few months to manage the chronic pain, and they've been reporting their primary care provider is refusing to prescribe it again until they have a mental health evaluation. The primary care provider believes Jennings may have illness anxiety disorder and needs a more in-depth psychiatric evaluation. Which of the following client statements would the nurse recognize as being a comorbid symptom related to illness anxiety disorder? A, when I think about my illness, I get very upset and destroy nearby objects. B, sometimes I can't remember driving to my healthcare provider. C, I feel like everything would be easier if I were dead. D, I relive stressful moments from my past when I hear certain sounds. So this one may be a little tough. I guess for me too. For this one, I get very upset and destroy objects. That seems like they're having like anger issues. I think this is more based on like anxiety or a depression thing maybe. Sometimes I can't remember driving home. This may be a dissociative issue, but I don't think that that's right. I feel everything would be better if I were dead. That also is a tough statement. And I relive stressful moments from my past when I hear a sound. That also could be like a PTSD kind of thing. I am going to say C. Oh, look, I'm right. So you answered C correctly. Clients who have somatic symptom disorder are significantly likely to have a history of depression. Clients often have feelings of hopelessness and helplessness, and providers are unable to find an underlying psychological cause for their symptoms. As a result, clients who have somatic symptom-related disorder are at high risk for suicidal ideation. Other available options are more consistent with a client who is presenting with dissociative disorder. Perfect. All right, so again, they're going to be talking about, the same thing, but just as an FYI, to reach a diagnosis of somatic symptom disorder, that has to be severely distressing and results in a significant disruption of daily life, such as job loss or any inability to function. You can go ahead and read the DSM criteria on your own, okay? When we talk about acute illness or illness anxiety disorder, it is a condition marked by elevated fear of having or acquiring a disease, high health anxiety, and behavioral manifestations such as repeated symptom checking or avoidance. Okay, so we saw this in the case study. And then this can look like constantly researching specific manifestations, continuously exaggerating manifestations. So like I said, stomach pain equates to cancer. Okay, headache equates to stroke. obsessing about body functions and vital signs, high levels of anxiety related to health status, or oversharing manifestations with others, or constantly seeking reassurance about these manifestations. Okay, and so please make sure that you're aware of these things. When we talk about functional neurological symptom disorder, this is used to be called conversion disorder. And remember that for this, they may have some neurological symptom that is not based in any sort of physiological concern. Okay. Factitious disorder. This is when the client knowingly produces manifestations to assume a sick role. We have two types. So you have fictitious disorder, and there's another one that is factitious disorder imposed on another. So this is what used to be Munchausen's. And so, like, a parent is, poisoning their child so that people would feel bad for the family, and it's really like a control anxiety thing that's going on. Okay. And so, fictitious disorder imposed on another person may be present if a family member or caregiver presents as the other as sick, when the parent falsely claims their child is ill. Okay, I have not worked in I worked in ERs that have pediatric ERs attached to them. So, like, it's a one-stop shop. We're ER and we're a pediatric ER because we have pediatric emergency doctors. But I've never worked at just a pediatric emergency room. And I'm pretty sure at pediatric emergency rooms, I'm pretty sure that there's a lot of factitious disorder imposed on another that are present. And essentially the reason why parents or guardians or whoever is doing this to get attention, and also it's a control issue. When we talk about dissociative amnesia, remember they can't remember certain experiences, so they don't have complete memory loss, they just have little holes in their memory. Okay, and this has just a couple of definitions that you may want to know. And then when we talked about depersonalization, derealization, as a reminder, dissociative identity disorder, this is that 2 or more personality disorders. Look up Sybil. And derealization, depersonalization, these are when they feel detached. So typically when we have a derealization, they feel detached from their environment, or the things that are around them may be unreal. And then when we have depersonalization, this is like a dreamlike state. They feel like they're just like out of body. It's like an out of body experience kind of thing. Okay. Please make sure that you click on these to look at some of the coping skills. Okay. I'm going to put that on you. And then when we get to the part 4 of the case study, I want you guys to kind of figure this out, and and then we'll discuss it in class. Okay. Or we'll discuss it in a tutoring session. When we're talking about the role of the nurse, the goal for you is just to help with improving or reducing anxiety and helping to improve the quality of the patient's life. So giving them antidepressants, also helping them with other coping mechanisms. Go ahead and read Challenges of Caring for Clients Who Have Fictitious Disorder. And then when we are talking about other things that we need to do, especially for patients that have somatic symptom disorder, cognitive behavioral therapy is a thing that we're going to do. So encourage relaxation, encourage mindfulness, positive thinking, setting up realistic goals, providing symptomatic relief such as pain medication or digestive relief, focus on communication of feelings and over symptom severity. Okay, so if they're constantly talking about their symptoms, focus on the communication and facilitation of the emotion versus, what the patient is talking about their symptoms are. Okay. All right, and then I do want you guys to go ahead and read all this. We're running out of time a little bit, but just skim through this as we skim through most things. And then we also talk a little bit more about this in class. All right? All right. Bye, guys. Happy studying.